Hey, good evening, everybody. Welcome to today's webinar, which is organized in joint cooperation between the Oncology and Pediatric section of EANS. The topic is very exciting, and I will thank you all for joining, and especially to our speakers, because if there is an area of controversy in terms of future therapeutic approaches, this is one of them. So I'm really looking forward to hear today's presentation, and I will ask everyone to prepare questions, to be active, and to use the opportunity to address the speakers after their talks. So please, just to start, I would like to introduce our two moderators, Professor Gordischer from Moscow, and Professor Simon from the oncology section of EANS, and I would love to ask them to start the webinar. Thank you very much.
Matthias.
Yes, of course. So a warm welcome also for me. And now I'm not only speaking as a neuro-oncological surgeon with a keen interest in pediatric neurosurgery as well. So I'm very happy to be invited to host this webinar together with you guys, but also in my function as the chair of the EANS tumor section. I think we are looking forward to a very nice and interesting and exciting webinar. Sergey, do you want to say something, or shall I just go ahead and introduce the first speaker?
Only a few words. Dear colleagues, as Anthony Raimondi said, children are not little adults, and newborns are not little infants. So we may suppose that in gliomas, molecular genetics may differ from between children and adults. The same may be with tactics of their treatment, including indications for surgery, chemotherapy, radiotherapy, and even target therapy. If it is truth or not, I hope we shall learn from this webinar. Okay, let us start.
All right. Then it is my pleasure to introduce the first speaker, which will be Gilbert Hangel from the University of Vienna and the Department of Neurosurgery there. However, he's a physicist, as I understand, with a great interest in high-field MRI, and he will tell us about advances in imaging and how that might relate to our topic. Gilbert, please.
Thank you for the kind introduction. Can you hear me still?
Yes.
We hear you very well.
Okay, then I now need to share the right screen. So you should see a presentation now. So yeah, I will start this meeting by giving a quick introduction about modern MR techniques that can be applied to gliomas. I will not delve into enormous details how they work, but rather focus on the output parameters and where multimodal imaging can lead us, in the sense that clinical interventions require information to decide on the strategy, information to control the treatment, to do monitoring. And for all of this, there are exciting new and old possibilities. So here in this overview picture, you see a few of the things we can do. Some things that are rather, I would call standard, like contrast enhanced, T1 or T2 weighted imaging, diffusion, then going to more advanced things like perfusion imaging by different methods, also functional fMRI that gives us information about the activation of brain areas during stimulation, but also metabolic imaging, be it CEST or MRSI. I'm an MRSI guy, so I will try to not show too much of my own favorite work, or advanced structural information like acquiring susceptibility weighted imaging or MR elastography. Some of you might not say, wait, advanced. My clinic is doing that in the standard protocols. I think here there's a huge range of how far clinics or diagnostic centers have progressed. Some that have the newest scanners are already able to do a lot of these things in default protocols. Some that have maybe 10 years old systems will be limited to what I would label here now standard. But first of all, I want to give you a bit of framework where I'm coming from in this context, and which is the GLIMA network. This is an European cost action about glioma MRI, which you can derive from the name. So it's a union of now I think 200 to 300 scientists from all over Europe and associated countries, as you can see here to the right. And our agenda is to improve glioma imaging mainly on a network level. So bring together researchers, inform people that are not in our club. And so we have 5 designated target groups. One where I'm the head is the advanced MRI biomarkers for glioma characterization group, where we really are more concerned with the technical developments. But then there are other important aspects: multi-site data integration, clinical translation, stakeholder relations, patient and clinic partnerships, also the dissemination, which is basically what we are doing right now here. You can see on the right an image from our second to last Klima meetings, where we have a wide mix of researchers ranging from neurosurgeons to radiologists to physicists like I am, and we try to advance the field of glioma MR. That's going into a few of the things that can be measured beyond standards. So here we see dynamic susceptibility contrast MRI, which gives us information about the perfusion. You can see this in the circle here on the left. Then in this area, which is a bit outside of the core tumor volume, we see actually increased perfusion, which could be a clinical indication that there is some infiltration going on. On the right, you can translate this actually into maps for fractional tumor burden that try to evaluate basically how much this hyperperfusion correlates to malignancy. So the red parts would be that are more concerning, which can also be applied to treatment controls. In this image, we see a patient, so ACE is before surgery and radiotherapy, and PDF is afterwards. And we see that these maps can give us information that in this case, treatment after resection radiation did not really control the tumor, and there's still a lot going on. This would be one of the important contexts that you can get from this kind of perfusion information, just from that alone. The next method is dynamic contrast enhanced MRI. Again, I'm not dwelling too much about in how they are working. They involve contrast agents, but what they can deliver. And here, this DCE can give us specific parameters like K-trans, and K-trans is basically a measure about how much contrast agent bleeds over time in the in the extravascular and extracellular space in the tumor. So basically a measure of blood-brain barrier leakage. So if K-trans is high, that means a lot of the contrast agent enriched blood crosses into these tumorous volumes. While VP is a measure for the free, as far as I understand, for the free water in the tissue. So if cellular borders break down and normal brain structures recede, that means that VP goes up. So this can also add additional information on the tumor context, which we can also see in this image, that it is that these measures are not identical to just doing a contrast enhanced structural imaging. So again, we try to acquire additional information, and some of these, like K-trans, are numerically on a scale or can be on a scale from 0 to 1. And this also means we get a bit more quantitative values than from conventional MRI protocols as they were done in the past. And that is a point I will lead up to very soon. We can even progress this further with acquiring more dedicated MRI protocols and then calculate a vessel imaging from this. So in contrast to just measuring some perfusion parameters here, which change in the tumor, you see here in this inside of this tumor volume, we have less perfusion, but to also calculate parameters like vessel caliber, so the size of vessels. So red would indicate bigger vessels, and vessel type, which can also add additional information about how actually a brain tumor, a glioma, is perfused in detail, which is again already more than just saying, yes, there's an uptake of perfusion or contrast agent. Diffusion imaging, I would say, is in its basic form a core part of clinical protocols, at least on our side. and it in the core form, it does give you an information about how much cellular borders or structures have broken down. So in healthy tissues, diffusion, so the random movement of particles based on thermal statistics, is limited by cellular walls and osmosis and so on, which can first of all break down in pathologies, and secondly can follow fibers in the brain or in the muscle, but we are now more targeting the brain. And from these weighted images, we can also calculate the ADC, the apparent drift coefficient. Basically, a higher value means that water can move more freely, so there are less cells or less fibers or less barriers around. And in tumors, basically, both can happen. There can be, especially after resection, more fluid pocket-like structures, or in areas of reduced ADC, we can assume that there are a lot of highly densely packed cells. So this can also correlate to cellularity of the tumor. What we also can do, we can not only look into the tumor itself, we can also look into the surrounding area, which you see in this image on the right side, where you can do fiber tracking. So from diffusion tensor imaging, you can then calculate how fibers are most likely structured in the brain. And it can add information about how these fibers are shifted by the growing tumor, where maybe important fiber bundles leading to cortices are pre-surgery, and how they need to be spared or resected. Or in this case of this study, here they did more statistical approach and looked to the differences between the side of the brain with the tumor and the other side of the brain, to show that also on population level, statistically, we already see differences. So this there's a lot of additional information we can acquire from advanced stuff, and at least we are even now trying to acquire diffusion tensor imaging with our intraoperative MRI to get more information that surgeons can use directly ahead of surgery. Again, in the vein of quantitative imaging, MR fingerprinting is a specific technique that uses a lot of assumption and acquisition magic to not only give us weighted imaging as T1 and T2 weighted standard protocols do, but from an MR fingerprinting protocol, one can derive a lot of quantitative parameters. Foremost of interest would be T1 and T2 times. So while A and B would be weighted images, in C and D, we would get really quantitative values, which again is leading up to a point I will make soon. Susceptibility weighted imaging has come up over recent times by the proliferation of better MR coils. So if you're really having a dedicated 32 or 64 channel head coil, SWI makes a lot more sense. And basically, the contrast of SWI is the susceptibility, which boils down to the presence of molecules that behave magnetically differently than regular brain tissue in that context. So in this patient, in the upper row, you see these dark blotches in the SWI, which in this case are blood vessels. So the blood with the iron particles in the hemoglobin are ferromagnetic and therefore have a highly different susceptibility, a much higher one than regular brain tissue. So here in this comparing these two patients, we can see the difference in tumor vascularization. So again, we can add different information, or to some extent, maybe in the future, it can also help already pre-biopsy or pre-surgically discern, for example, a glioma from an atypical meningioma that has a lot of calcifications in there. There's a lot of information one could get from this. And you see this vessel information is way more specific than the T1 contrast enhanced images. Another modality is MR elastography. So here we're considering about elastic or stiffness information of the tissue, which was for a long time only done in more softer tissues, for example, for the liver, because the skull is, of course, a big obstacle for using sound waves reliably. So MI elastography requires additional equipment. You need a transducer to send sound waves in, but you can acquire as parameters the stiffness of the tumor, so basically how firm is the tumor tissue, and also some properties of the reflections of these waves. Again, we can add more quantitative parameters to our information. Now we're coming to the metabolic imaging part. So one is the chemical exchange saturation transfer imaging test, which basically looks at how molecules interact with water concentrations after specifically exciting them. And what you see here is in theory a measure of the amount of other molecules than water that are present that you can select for in your imaging sequence. And the clinical test that is available now basically looks for amide sequences. So basically some indication, I would say, of amino acids and similar molecules that have some kind of NH groups. And this, of course, can give us information about this metabolic activity. So in the Krebs cycle and in fast-growing tumors, we know, as also from positron emission tomography, that there's a lot going on with amino acids, and this can be to some extent imaged by CEST. And one example, so while this on the left side is preoperative imaging, where you can see, depending on the specific CEST methods, you can also lipid suppress CEST. You can see also different metabolic activity in the compartment that nicely fits the morphology you see in BNC, while the image on the right side shows post-treatment data. And here we have one patient where CEST shows a lot of activity in this unclear situation. Is it radiation necrosis? Is it recurrence? And CEST would indicate that patient A indeed has more recurrent property, while the more cold spot behavior in the patient B indicates that it's more like a case of radionecrosis. The next one, so my home modality, is MR spectroscopy, which looks at resonances different than water. They have a far less strong concentration and are therefore more tricky to image. So you might know it from your clinical experience as a single voxel or very low resolution MRSI. And usually it's tricky to get one good voxel in the tumor. But here in this case of single voxel in APNC, we can see the differences in the spectral behaviors between a healthy control voxel in B and the tumor voxel in A. Most importantly, clinically, is the decrease of NAA, N-acyl aspartate, which is a marker for regular astrocytal activity, while choline as a molecule associated with membrane transport increases a lot. You see it here in relation in gliomas. So clinically, you would most likely look at the ratio of choline to NAA and also have a bit a look at lactates indicating changes here in these aerobic and anaerobic processes. And the basic point of spectroscopy would be theoretically that we can get a lot of information about different molecules that are involved in the TCA and ATP cycle. So up to 2-hydroxyglutarate, which is associated with IDH mutations. And we know that IDH mutations are very important as markers for the WHO 2021 classification. This is limited to single voxels. My own work concerns about more like going into 3D resolution, as this example shows, with high resolution images and at 7 Tesla, resolving more molecules than at 3 Tesla. So we have, for example, here choline, but also glutamine and glycine, which as amino acids correlate a bit better to PET from our data. And you can see, depending on what's going on here between the signal void and this heightened activity, that there is maybe some interesting things going on outside of the morphologically visible tumor borders. We are exploring now if we, for example, can track infiltration better with this method. But there's a lot of ongoing work, and this is not widely available right now. Give us 10 more years, then hopefully it is available on clinical several Tesla scanners. Outlook-wise, there's also the possibility to look at other atoms instead of hydrogen, for example, deuterium. So you can, alternatively to PET, you can give people deuterated glucose and then look at the glucose metabolism in tumors. You can do that directly, like here in A, you give them glucose, and then you see a buildup of signal, and you avoid the H1 contamination. On the other side, you can give people the deuterated glucose, and you look what happens in the proton spectra. So you see a reduction of the proton signal when deuterated sugar goes into the cells. So with this, I'm coming to the point why we do all of this. Because all of this would blow, you cannot do all of this in one patient in one session anyways. We have enormous protocols, but we can get information on oncometabolites, on tissue stiffness, vascularization, perfusion, susceptibilities or presence of iron or calcium, brain function with fMRI and also DTI, fiber tracking. We can quantify relaxation times. Because we can use this multimodal imaging as a good base for prediction. So here you have a lot of modalities on the right side, and in the end you could, for example, calculate a probability map for tumor recurrence, which would be much more usable for monitoring than just throwing 10,000 images at your radiologist and expect them to go to all of these in 5 minutes, which of course is a matter of AI. And here the point is, radiomics features can be tricky to get from just weighted or qualitative data. Then you often have to recourse to higher order features like how is the distribution of my voxels, how is the volume, how is the shape of whatever. If we get quantitative values like T1 values, some parameters like ADCs, some K-trans or whatever, we can deliver, and metabolite concentrations, we can deliver better inputs for these machine learning models to classify better. The more and the better information, the better the output should be. To some extent, work is already tried. So this is from the Stadelbauer group in Erlangen, who basically mapped tumor microenvironments. So from several contrasts, they calculated basically distribution maps for different kinds of metabolisms, which would show how active tumor compartments are, what kind of Warburg processes happen there. So again, delivering additional preoperative or tumor monitoring information. This was, of course, now a very, very, very short introduction of all of these techniques. If you want to have any idea what they're actually doing, you can look up a lot of these papers. So Gliomas released a lot of review papers with the aim to show the clinical community what is available. So we have our basically founding paper, and we have 2 double reviews out on pre and post-operative classification of gliomas, which contain a lot more of these details and references to find stuff. And of course, if you have specific ideas about projects, you want to join the community, you want to network, find collaboration partners, please join our community. While EU funding is running out now very soon, the community will still go on and connect scientists all over Europe and the world. With that, I want to thank you for being here today and listening to me. I want to thank my colleagues at my research group at the Department of Neurosurgery in the Havel-Demar Center, the students that start now doing the work for me instead of me doing all of it. And if you want to contact me, you can reach me with the information on the right side of the screen. Okay, with this, I'm coming to an end now. Thanks.
Thank you, Gilbert, so much. So I think it's a very interesting lecture and very useful for the neurosurgeons. So at moment we have no questions, but the practice shows that questions appear in some time.
Yes, please post them in the chat or in this question and answer module, and I'll be back for the discussion at the end.
Yeah.
Thanks again.
Yeah, thank you.
Right then, I think we should go on, and then my list, Sergey is the next speaker, and he will talk about optic gliomas. This is how they were called in the earlier days, right?
Mm-hmm.
Sergey is a professor of neurosurgery at the Budenko in Moscow, and is a important and somebody I know for quite a while in the EANS. He's the outgoing chair of the EANS pediatric neurosurgery section. So I think, Sergey, we're all looking forward to your talk.
Yeah, Thank you so much for this kind introduction. I believe that chiasmal gliomas in children are very specific tumors. So chiasmal gliomas are very specific to the children and to the young age. Our lecture is based on the material of Burdenk Neurosurgical Institute, and during many years, I think that it's about 1,000 cases, I mean surgery for chiasmal gliomas. So, but we analyzed about 300 cases during 10 years, and we have come to some conclusions. So first of all, this is a very well-known Dodge classification. I think this is the basic one and advanced scheme. It is very pity that our own Russian classification was elaborated before this one, but unfortunately it was not published. So, and it is based on the origin of the tumor origin along visual pathways. So it may be originated in the intracranial part of the optic nerve, in the middle of chiasma, in the posterior part of chiasma, and at the optic tract. So it will be different appearance. So the fifth group is the gliomas of the third ventricle, which are, in the majority of these patients, we reveal hydrocephalus, symmetrical deterioration of visual, and favorable prognosis for vision. Another type of the tumors, this is the diffuse tumors of visual pathways. So these are quite different. They infiltrate, they has an infiltrative growth along visual pathways, bilateral invasion, and the presence of neurofibromatosis type 1 in the majority of such patients. So these tumors will also classify into different types. This is the anterior type of the tumor, which involve visual optic nerves. So this is the chiasmal types. So this is like butterfly. The posterior type, which extends to the brainstem, to the quadrigeminal, and to the both thalamus along visual tracts. We revealed that in many patients there may be two phases of growth. During many years, the tumor may be silent and then explode in one of the parts of the visual pathways. It may be in different parts, and then it may begin to grow very rapidly. So this is a case of such a progression. During several years, the tumor was passive, then enhanced gadolinium, but the same size, and in some other period, so we see the rapid enlargement of the tumor with cyst and the growth of the solid part. So our treatment strategies were as following, shown on this slide. So the majority of patients underwent surgical removal, and then we used chemotherapy, radiotherapy, and in many patients, observation. So speaking about the surgical treatment, we use different surgical approaches for different tumors, for different tumor types. This is the subfrontal approach for the gliomas of the anterior part of chiasma. For the gliomas of the middle part of chiasma, we may use the transcallosal approach alone, but this is the part which we can reach with this approach, and this part of the tumor may be removed, but this part will be remained invisible. On the opposite, the subfrontal approach alone may let us to remove the basal part of the tumor, but the superior part of the tumor will be left. So the pterional approach is used for the gliomas of the visual tract. This is a very common approach. And for the gliomas of the third ventricle, the best approach is the transcallosal one. And in some cases, we use the transcallosal approach with the endoscope assistance. So this is the geometry of such an approach. This is the bone flap. This is the dura incision. This is a hole in the corpus callosum. And this is the most posterior part of the microscope vision. This is the most anterior part, which we can see with the help of the microscope. This part of the tumor will remain invisible and inaccessible, while this part may be removed. But for the removal of the most anterior part of the tumor, we may use the endoscope, the assistant endoscope with the angled optics. And now I may show you how it is maybe performed. So this is the view through the foramen of Monroe, and we use the angled optics of the endoscope, and thus we can remove the tumor from the most anterior part of the third ventricle, thus not to apply the damage to the anterior edge of foramen Monroe, to the fornix. So, this method helps us to perform the maximal safe removal of such tumors. Of course, the basic part which infiltrates the visual pathways, in any case, should be remained untouched. The surgery for diffuse tumors, no, of course, but in many cases, we have to perform biopsy in order to proceed with chemotherapy or radiotherapy. For this purpose, one can use the visual evoked potentials. So we use two modifications, potentials to the light flashes and the direct stimulation of visual pathways. This may be performed with the help of the supraorbital keyhole approach. So on this video, you can see the probe of the neurophysiological device, and you may see the typical evoked potentials from the one part, and nearly the absence of the visual potentials from the other part of the tumor. So this is the best place for the tumor biopsy, the most distant from the active visual pathways. So the results of our surgical treatment, mortality remained in the previous years, so now we have no mortality. Complications are due only to the water electrolyte disturbances. And very interesting, the dynamics of endocrinological functions. So after surgery, we have much more patients with a precocious puberty. The weight gain as well. So you see, this is the figures before surgery and after surgery. And the very interesting situation with cachexia, which is due to the many patients of the youngest age. What is the most interesting, that after even partial or partial removal or even biopsy, the cachexia disappear. So we have such a child with cachexia before surgery, and in 10 months, it is very nice child. So stereotactic radiotherapy. So the classical indications are the progression of a tumor after the partial removal or after chemotherapy. Contraindications may be the neurofibromatosis and the children less than 4 years old. Of course, we use the stereotactic radiotherapy for all these patients in order to prevent the excessive dosage to the functional errors of the brain. But the stereotactic irradiation on modern equipment has minimal complications. I mean secondary tumors and development retardation of children. So it looks like this. This is the involution of a tumor after irradiation in several years. You see, this is the involution of a tumor. The follow-up after radiation therapy, after the removal of the nodule type of the tumor, surgery plus stereotactic radiotherapy. This is the yellow partial response, and the rest of the patients with stabilization. So in some cases, the red square, these are the recurrences. So, but nevertheless, the results are very favorable. So with neurofibromatosis type 1, we have nearly the excellent recurrence-free survival. And in general, this is about 90–93%. So, and what is the most important, that we had no secondary tumors out of 150 radiated children. Even there were 34 children with neurofibromatosis type 1 with the follow-up period more than 10 years. So we think that it is due to the modern strategies in stereotactic radiotherapy, conformal radiotherapy. And this is this conclusion is supported by several papers. So, for example, in this paper, these data show that estimated risk of intracranial secondary malignancy or malignant transformation of a benign tumor in patients treated with stereotactic radiosurgery remains low at long-term follow-up. And what is important is similar to the risk of the general population to have a primary CNS tumors. Okay, the dynamics of visual functions in such a patients are shown here. Improvement and stabilization in the majority of patients. What is interesting, in some group of patients, we can see the improvement of visual functions in the follow-up period. And this is due to recurrences. So, and again, the endocrinological functions, now again, after irradiation, are showed here. So here we can see the weight gain much more prominent than after surgery. This may be a disadvantage of radiotherapy. Now about chemotherapy. So we used the chemotherapeutical protocol, COP-LGG. It is very well-known protocol. So, and this is response of a tumor at the 24th week. The oncologist will understand what I'm speaking about. So this is the partial, objective, stable disease, and progressive. And for neurosurgeons, I can explain that this is the complete response at week 24 of the chiasmal glioma. This is the partial response at chemotherapy at week 24. This is the stable disease, what is not bad. And this, unfortunately, the progression, and then we have to come to the decision what to do further. So, about risk factors, what do we have now? So, there are several risk factors for the chiasmal gliomas we can define. So, the first is the age of a patient. So, the younger a patient, the worse results. So the presence of diencephalic syndrome is also a risk factor, and its presence is a negative factor. Histology. So, of course, you know that there is no pilemyxoid astrocytoma in the modern classifications. But nevertheless, so this investigation was performed during last 10 years. And so at that moment, we defined the pilemyxoid astrocytomas, but from the neurosurgical point of view, from my point, they really differs. So at surgery, and pilemyxoid astrocytomas has a much worse prognosis than pilocytic one. So the presence of neurofibromatosis type 1 is a positive factor, and the patients with it has better prognosis. And the localization of the tumor also plays a role. So the anti-chiasmal or Dodge1 group of patients has an excellent prognosis. I think because all of these tumors may be removed with a gross total or near gross total, of course, removal. So, and if we try to analyze all these three risk factors in combination, so we shall see that in those patients whose age is younger than is 1 year, with the pylomyxoid astrocytoma, with cachexia, so they have much worse prognosis. So this is quite another patients than patients with older age, with the typical pilocytic astrocytomas, and with neurofibromatosis type 1. So, and this is very important diagram. So we compared different strategies, so, and revealed that chemotherapy alone without surgical removal shows the worst results. The surgery alone also not very good. The surgery plus chemotherapy shows much better results. And we can see that surgery plus radiotherapy may pose the best results. But here we may have two exclusions, the neurofibromatosis and the young age of the patients. But as I have showed you in several papers, they say that these may be not the contraindications for the radiosurgery. Perhaps we may discuss that during our webinar. So another option, this is the target therapy. There are most frequent mutations are the BRAF fusion, BRAF V600E, and of course neurofibromatosis type 1. But the good news that now we have BRAF and MEK inhibitors that may influence the strategy of our treatment and shows favorable results in those patients where they were used. So this is one of the examples taken from the ISPN guide from the site. So you see, this is the pilocytic astrocytoma with V600E mutation responding to vemurafenib. Sorry. So in general, this is a big hope on the BRAF and MEK inhibitors, which can stop progression of the low-grade gliomas in the functional areas, such as visual pathways. This will help neurosurgeons to perform partial or subtotal removal and thus to preserve vital structures. So, and to conclude, this is our strategy in the treatment of these tumors. So if we have a patient with the neurofibromatosis type 1, in the majority of cases, this will be diffuse tumors. So we may spend some time for observation. And in cases of a progression, we shall perform chemotherapy. So the results are shown on the bottom of this slide. If we have a patient with negative neurofibromatosis, so in the majority, these will be the patients with nodular tumors. That's why surgery may be performed in these cohort. Then, at the age of less than 18 months, again, in the majority of this patient, we shall face with the gene tumors. And in these cases, the chemotherapy will be the first-line therapy. So the prognosis and the results are shown. If the age of a patient is more than 18 months or 2 years, in the majority of these patients, the tumors will be pilocytic. And here we have two options, to perform chemotherapy or radiotherapy. The results are compatible, but the radiosurgery shows a bit better result. So thank you so much, and you are welcome to the in-person webinars in Moscow. Thank you.
Right. Thank you, Sergey, for the very, very interesting talk. There seem to be no burning questions in the question and answer department, but I have one for you, real quick one. What do you think of a strategy of, let's say, obtaining a biopsy in a very, very small child, 3 months old first, then do chemotherapy and prepare for doing a larger surgery later on? Sort of a staged
thank you.
Management.
Yeah, you know, based on the MRI scans, as it was brilliantly shown by the first speaker, so we can propose the histology of the tumor. As for me, I think that in 100% of cases, we can suppose that we have the chiasmal glioma, so the astrocytoma low-grade tumor. But in the majority of cases, if we have no neurofibromatosis, and at this age, it is very difficult to define. So in the majority of cases, the oncologist will ask us to perform the biopsy. And of course, in these cases, we shall perform surgery, first of all, for the biopsy. For the next task is to reduce the volume of the tumor, and thus to create the better condition for the future chemotherapy.
Thank you. So since we have no further questions, I think I'd like to call the next speaker, which will be Professor Francesco Signorelli from the University of Bari in Italy. He's published in all areas of neurosurgery, skull base, with a focus on the craniovertebral branch and vascular and so forth, but also on eloquent tumors. And from listening to one of his last talks, I understand he's an interest in pediatric neurosurgery as well. And this is why he will talk about diffuse midline gliomas. It's a pleasure to have you, Francesco.
Thank you. Thank you very much. Good morning. Thank you very much for this kind invitation. I'm really thrilled to be a part of this outstanding panel. I'm really enjoying this webinar. So I'll get straight to the heart of my presentation, show you this case of a 7-year-old girl with a 2-month history of clumsy gait, 2-week history of headache upon awakening. She had a left hemiparesis and a right cerebellar syndrome with an ipsilateral 6th nerve palsy associated to what one may think is a typical diffuse intrinsic pontine glioma. So maybe we could even pass and put an indication for biopsy, although if we have a closer look to the spectral MRI, what we can maybe notice is that the ratio, choline-creatine ratio, is not so altered. There is also, again, significant N-acetyl aspartate peak with no lactates, no lipids, so no markers for necrosis. So we may think that this is one may fall in the 10% of low-grade DIPG, and this is the reason why, on this ground, this is the MRI, the multidisciplinary audit indicated biopsy in this case. The next step would be to choose the target, to choose the trajectory. We prefer to go through the middle cerebellar peduncle, which is quite large, but the target and the trajectory is also an important question because, for example, we should avoid to be too low, like for this cut, because if we are too low, we are too close to the pontomedullary sulcus, which is, as we very well know, the exit zone for the 6th, 7th, and 8th cranial nerve. Also, if you are too caudal, we may endanger the pontocerebellar crossing fibers, which are the fibers that make the connection between the neocortex and the neocerebellum. Well, we should also avoid the necrosis, but the safe entry point for the ventral pons remains, to my advice, the middle cerebellar peduncle, providing that the trajectory goes through the middle of it and stops before getting to the base of the pons, for avoiding, obviously, the pyramidal pathways. With this trajectory, we may avoid also the medial lemniscus and all the cranial nerves nuclei. And this is what we did. This is the post-biopsy MRI that shows the trajectory of the needle, where we did our several samples. And the diagnosis was a diffuse pediatric type, high grade, not low grade, unfortunately, but high grade glioma, H3 wild type, with Ka is 67-10%, hyperexpression of P53 in the 10% of tumor cells, no necrosis, no endothelial proliferation, but still the immunohistochemistry is more important than the microscopy. So we retained the definitive diagnosis of a diffuse high grade, and the girl was started on nimotuzumab and vironelbine before radiotherapy. Then she underwent radiotherapy. She continued the same chemotherapy regimen up to the 6th month MRI, and the 6th-month MRI unfortunately showed progressive disease without clinical deterioration. So she underwent re-radiation and continued the same chemotherapy for another 3 months, when she had a further progression of the tumor and a clinical deterioration, and she was started with temozolomide, etoposide, and everolimus. So we have a follow-up of 12 months with a stable disease now. This is another case, another entity for concern the diffuse midline gliomas. Is an 8-year-old boy with a 2-month history of difficulty in concentration, so recent history of headache, vomiting, and he was admitted in intracranial hypertension syndrome. He had a Glasgow Coma Scale score of 13 and the right hemiparesis. So he underwent an emergent EVD. Then we discussed the case, and we decided for surgery, not just for biopsy, but for resection surgery, on the ground that a shunt or CSF diversion would be really unlikely to have a long-term effect on intracranial hypertension. And having a closer look to the MRI, we judged we could spare the supracapsular, capsular, and infracapsular motor pathways. And if we chose the trans-intraparietal sulcus, we could also spare the visual pathways and the language pathways. One important caveat is the inferior extension of the tumor toward the quadrigeminal cistern toward the ambient cistern. That would be the most difficult part of the tumor to take out. This is the spectrum MRI that is in favor of high-grade glioma. And another caveat is the close relationship of the tumor with the deep veins, and also some elements in favor of a high vascularization of the tumor. But at the end, we chose for surgery. I'll show you short video. So the patient is positioned as for the figure here on the same side, on the ipsilateral side of the tumor, to use gravity as a retractor. Here we are using the cortical motor potentials, and we are going to go through the intraparietal sulcus. So this is the primary sensory area, and that will be we will be able to open the whole sulcus, this is the midline. So as you see, you will see we are using just one spatula just to hold the brain, not to retract it. We are opening the ventricle here. You recognize the choroid plexus, the choroidal vein, and the ependyma that covers the tumor. So we are coagulating the ependyma, we are coagulating the vein. We are going to open up the ependyma to expose the tumor. Here, this is the grayish tissue, the tumor. Then these are samples for frozen section. This is the anterior, we're going through toward the anterior limit of the tumor here, and it is toward the lateral limit of the tumor, obviously debulking, setting correctly the CUSA in order to spare the intra-tumoral vessel you'll see in a moment. Here, this is the choroid plexus that takes part in the vascularization of the tumor. We have to coagulate it and cut and expose more surface of the tumor, taking out the ependyma that covers the tumor. We can sometimes also dissect the ependyma from the surface of the tumor. This is the floor of the atrium. Again, you see, setting correctly the CUSA, we can spare the vessels inside the tumor to coagulate them. These are the branches from the choroidal branches of the PCA that we can divide, we can isolate and divide more branches coming from the midline, from the choroidal fissure. This in order to reduce the bleeding, the bleeding during the debulking. So you see, we can spare vessels, stop, coagulate them with the right setting of the CUSA. Here, this is a demagnified view that shows us the ependyma covering the tumor, more debulking. I'm trying to skip this. So this is the septum pellucidum that we are dissecting, we are isolating from the surface of the tumor, medial surface of the tumor. We are approaching the choroidal fissure, so the telochoroidea. We are dissecting the telochoroidea and coagulate the veins that drain the tumor, the thalamus, which is infiltrated by the tumor, in order not to avulse the deep veins. And we are approaching the medial limit of our resection. Another problem would be here at the level of the lateral wall of the ventricle, where there is no clear, this is the posterior part. These are the lateral surface of the midbrain, the posterior, the PCA, the posterior cerebral artery, the Rosenthal, the branches, the posterior choroidal arteries, and those the tags indicate the supracapsular pyramidal pathways. We are using an aspirator, which is also a monopolar stimulator, in order to go flush to the pyramidal pathways. Don't have any clear limit with the infiltration of the lateral wall of the ventricle, but we can use the monopolar stimulation in order to stay away a couple of millimeters, 3-4 millimeters from the pyramidal pathways. This is the final product with all the course of the pyramidal pathways superior to the internal capsule. This is the groove between the head of the caudate nucleus and the thalamus, where the knee of the internal capsule is, where the corticonuclear fibers are. And we are opening up the septum pellucidum in order to avoid an excluded ventricle, and we are with the endoscope controlling that the contralateral foramen of Moro is also opened, and this is the final product with a couple of centimeters of approach through the intraparietal sulcus. So this is a postoperative MRI. Obviously, there is tumor attached to the lateral wall of the ventricle at in contact with the pyramidal pathways. The final diagnosis was diffuse midline glioma H3K27 altered with a Ka 67 or 15%, BRAF negative. The patient underwent was hospitalized in our rehab facility, but we have a follow-up of 1 year now with a stable disease, an MRI, and a modified Rankin score for children of 1 with no residual disability, and he attends a regular education. Obviously, he underwent immunotherapy, chemotherapy, and radiotherapy. So a couple of remarks about those two entities that I showed you. For what concerns the pontine gliomas, they are surgical and treatable because they can be reached, but they do not displace, they infiltrate the functional tissue. Moreover, they can and frequently encase the basilar artery and their perforators and can be highly vascular. However, diagnostic biopsy is feasible with a diagnostic yield that approaches 100%, with a very low mortality and permanent morbidity rate, with no age limit for the biopsy. Nonetheless, neurosurgeons often deem biopsy not needed routinely, and this is indicated by the SIOP brain tumor group survey, where neurosurgeons generally indicate biopsy only in trials. However, we think that biopsy is sometimes even clinically useful because may clear the prognosis and sometimes even guide treatment. For example, in cases of the IPGs with an increased mitosis, this suggests a very aggressive treatment from the beginning. And also, the studies, new studies, the ongoing studies and future studies, they need biopsy, they need samples to find new markers and targets. And this is the case, for example, for new recent evidences about the possible target in the PI-K3 inhibition. For what concerns midline gliomas not centered, diffuse midline gliomas not centered on the brainstem, there are some series that do not find the location brainstem versus non-brainstem a prognostic factor. And also there are some series that do not find the extent of removal prognostic. And even the cases like ours with a giant tumor, more than 5 centimeters of maximum diameter, a dismal prognosis. What we think is that actually there are indications in selected patients for surgery. Surgery in selected patients does change survival, does change, improve quality of life, providing that we aim to a maximal safe resection using, and those are very useful tools, neuronavigation, obviously, fluorescence dyes, but more overall, I think the knowledge of the anatomy and the functional neuroanatomy is really the key in some cases. So just to conclude, I think, well, it is obvious that the management of diffuse midline gliomas should be based on a multidisciplinary discussion with the aim to go beyond the protocols and at the end to individualize the treatment for those patients whose prognosis is often dismal. So with that, I have concluded my presentation. This is my city. I invite you and look forward for discussion. Thank you very much.
Thank you. Thank you, Francesca. For me, it was very interesting report. So you see, concerning the questions, we have a bit strange situation. I suppose that we may have some technical problem because we have no question, and some of the questions I have on my WhatsApp phone. Perhaps I'm afraid that we may have some technical problems with the chat with the participants. So, for example, one of the questions was to Gilbert. So the question is, to what extent is it possible to predict the histology, grade, genetic mutations, and so on? I think you have partly answered this question, but nevertheless, perhaps you may elucidate it once more.
Can you hear me?
Yeah.
Okay. So right now, most publications on this are about the performance of a single method that is put into an AI model, and most manage area under the curves of around 0.8, 0.85. There are some that try to pull more stuff in, but the short answer is with most methods, you can, for example, get IDH status or another parameter with a confidence of an area under the curve of 0.8.
Okay. Yes, and you see, again, a bit strange. So the next question, which they sent to me, how does our knowledge influence our tactics in DIPG? So I think this is the question to Francesco.
Yeah, as I showed you, even for a classic biopsy, it is important to know really in depth the anatomy, the functional neuroanatomy. And with this in mind, even biopsy of a very infiltrative tumor can have a mortality, well, actually a virtual mortality, no mortality at the end, and a really low rate of permanent morbidity, less than 3%. So, but still, it is very important. In some cases, one can also change strategy and use a coronal burr hole. I'm not excluding that. But for example, when the IPG goes up toward the mesencephalon, toward the thalamus. But generally, what we prefer, and I'm aware this is not, the thought of all the pediatric neurosurgeons, we prefer to go through the middle cerebellar peduncle, which is the least function.
Okay, so questions begin to appear. So the question to Francesco Signorelli from Andrei Gavrushin. Do you have experience in the use of liquid biopsy techniques in the diagnosis of the midline brainstem gliomas? A good question, yeah.
Well, we have an experience on research, but it's not really clinically useful for now. Yeah, it's it is useful, and it is a topic for research, but clinically we still need the biopsy, real biopsy.
Okay. Oh, yeah, great. So I have awaked our participants. So question from Miroslav Fimic. Can DTI be helpful for approaching the IPG?
No. Yeah, yeah. I mean, DTI is Gilbert showed us. It's a probability map, so it can be useful in planning. Need to be confirmed intraoperatively with direct mapping. I don't know what Matthias think about that, but we can rely on it for the preoperative mapping and to have another element, another information, but we really need in intraoperative mapping. What do you think, Matthias?
Yes, right. Yes, you're right. I tend to rely on intraoperative mapping as well, and not so much on imaging information, actually. Yes, DTI can show you the fiber tract. And for example, in the case with the thalamic glioma that you showed, I would have gotten, I guess you probably had DTI fiber tract mapping to get an idea where the motor tract is, but intraoperatively, I think some kind of functional mapping, MEP, and direct stimulation is essential if you approach these lesions. Actually, since you're talking about that, how do you stop resecting? Well, if the tumor has a diffuse border, how do you stop? Aren't you concerned about, well, bleeding and all this? Well, probably you are.
You are talking about the biopsy of the IPG.
No, I'm talking about the thalamic tumor.
Oh, about thalamic tumor. You have to take it out, most of it, otherwise you will not have any good hemostasis.
Yeah.
But that's why you have to carefully study the images beforehand.
Mm-hmm.
And if it is really diffuse, these an element against surgery. If as in the case I showed you, the mass is quite limited, the limits are really sharp. Yeah. on T2 and flare, you will expect less bleeding because you will find the margins. But generally the bleeding is really in the core of the tumor. It's very difficult to have a diffuse brisk bleeding in the margins. But still, using the CUSA with the cord secting, with just a little bit more vibration and just a little less sucking, you can isolate the vessels and coagulate them one by one to decrease the bleeding, the intraoperative bleeding, as I show you.
Francesca, the very similar question, where to stop? So do you use the neuromonitoring intraoperatively? I mean the direct stimulation of the motor pathways in the cases of thalassemies.
Yeah, I showed you that while approaching the lateral wall of the ventricle, where the supracapsular pyramidal pathways are, we use an aspirator that is also a monopolar stimulator. So in this way, we can aspirate the tumor without the CUSA, but with the aspirator, and at the same time stopping the registration, the recording from the cortical motor evoked potentials, but using direct stimulation, monopolar stimulation, setting the monopolar stimulation at about just a bit less than 10 milliampere to give to stay away from the pyramidal pathways at least about a couple of millimeters. Yeah, 2-3 millimeters. But still, we can go really flush to the pyramidal pathways in this way.
Matthias, we have a lot of questions now. So should we proceed with the reports and then answer all the questions, or what do you think?
Maybe we just answer the questions real quickly. For example, there's one by Elena who's asking that what Francesco, what do you mean when you say that surgery is indicated in selected cases?
Like the one I showed you.
Like the one I showed you.
Indicated when your appreciation of the preoperative radiological workup shows you can take out at least 90% of the vision.
Is there a standard care plan for diffuse midline gliomas? What is the prognosis in your institution?
The prognosis, well, you know, there are very, very rare cases. So I'm in Bari since 2018. I think we diagnosed a couple of them each year. So that was one of the last cases. The prognosis is less than 1 year in general.
There's one question for Sergei. What is there a threshold of how much of an optic glioma has to be resected to influence outcome? Is there a threshold? Do you have to take out 70%, 80%, 50%?
No, there is no such a red line, for example, as in medulloblastomas, where we know about 1.5 square centimeter, which influence the oncological prognosis. But in the chiasmal gliomas, especially in the youngest children with the GN tumors, so we remove the tumor. Our task is to decrease the volume of the tumor in order to in cases when it is block the CSF pathways, so and to make more favorable platform for the future chemotherapy. So we remove the tumor, coming closer and closer to the visual pathways. And if we see the pathways, if we see the visual nerves and chiasma, or we can detect the activity by the direct stimulation of the visual evoked potentials, so here we stop. So this is no red line, but we try to remove the maximum volume safe, the maximum safe volume.
Then one question for Francesco again, with respect to the is a biopsy in diffuse midline gliomas obligatory? For example, in Pontine, is a biopsy obligatory or just something that can be done on an individual basis?
This is the question. I mean, we tend to do biopsy. We have a closer look at the multimodal MRI. In the case I showed you, that was an indication that could be one of the rare low-grade or lower grade, the IPGs. Generally, we tend to do biopsy also for research purposes. We are involved in a research project, a European research project. So we tend to do research. But yeah, the question is it useful or not? Sometimes really clinically is not so useful. Right. So it has to be discussed in a multidisciplinary team.
Sergei, now the questions start coming in, but we're a little bit short of time. So I guess we will leave it as it is at this point, and we'll try to answer the questions maybe by writing little notes. And I guess you want to introduce the next speaker, won't you?
Okay, so our next speaker is Karsten Nisom. Yeah, right? Am I right? So sorry for pronunciation. And the speech will be devoted to the specificity of postoperative chemo and radiotherapy for gliomas in adults and children, what a neurosurgeon needs to know. So please, you are welcome with very important speech.
Thank you for having me here. I hope you hear me well.
Yes, excellent.
Yes, and you see my slides in the right way?
Yes, as well.
Good. So greetings from Copenhagen. I feel rather odd coming into this meeting because it is really a pediatrician or a pediatric oncologist coming into the arena of the neurosurgeons. I would like to say I agree very much with one of the last comments of the previous speaker, namely discuss it at the multidisciplinary team meeting, because of course there are situations where you need to make a surgical decision immediately, but for very many children with brain tumors, you have time to discuss with other team members, and for me that is key. I do also acknowledge that when I began reading about how to treat brain tumors in children many years ago, it said everywhere the most important thing is how good a neurosurgeon you have. So it is, you are key actors in this. Let me see if I can advance the slides. So I'm based in Copenhagen, Denmark, which is this whole hospital, the tertiary center. The neurosurgeons are, let me see if I can do a pointer. I can do a pointer here. Yep. So my neurosurgery colleagues are over here in the new building. Pediatrics are in this building. It's only 50 years old. I work in the trials unit, so we're down in the basement here. But luckily, they are now constructing this thing, which is going to be based up here where I point now, so up behind this White House. So in a few years, we will have somewhere new to be. So greetings from Copenhagen. I'll try to touch on these things, something about glioblastomas, diffuse midlines, low grades, optic pathways, and then something about the new things. So just to move a little backwards, I reviewed some of the epidemiology work. As you know, brain tumors in children is rather rare. So I and my colleagues, we work, of course, nationally, but our home ground is really the region. So we work with all the Nordic colleagues, and that's how my colleague and friend Radek Fritsch from Norway reached out to me and suggested me to speak here. So based on a Nordic analysis about 10 years ago, the incidence is about 42 new brain tumors per million children. So that means a country like Denmark, where we have 6 million, it will be something like 40 or 50 new cases per year. Our Swedish colleagues some years before made very good detailed analysis of all the subgroups. And since we speak about gliomas today, they make up about half of them. So in my country, there would be some 40 or 50 new brain tumors a year in children, and some 20 or 25 gliomas. Optic pathway gliomas make up a fraction. Other low-grade gliomas, much more, and I think it means there were an optic pathway glioma group that were not biopsied. So altogether, about 40% of all brain tumors are low-grade gliomas, biopsied or not. And then there are the few high-grade gliomas where we have the diffuse midline ones and we have the hemispheric ones. General perspectives, it's certainly well known to you, but molecular classification of tumors is nowadays key with the methylation array to supplement for sure the pathology workup with the histology, and in very many centers the sequencing of tumors tissue, be it whole genomes, whole exomes, or at least panel sequencing. I would expect that there are still parts of Europe where every center don't have access to these molecular analysis, but it's becoming less and less, and at least panel sequencing can quickly be cheaper than a couple of fish tests or other more complex pathology tests. One thing that I forgot to put in here is actually in many countries now, there's also research to focus on the germline sequencing of children. There's a lot of research going on looking into whether there are more cancer predisposition syndromes than we already knew about. And that changes for some things, including the low grades, where some of the low grades come in a NF1, neurofibromatosis 1 background, and as mentioned by Professor Sergei Gorelishev, sorry if I don't say it right, from Moscow. In the young, it can be very difficult to see, but of course in the gene, you can easily determine it. So I think we will move into a point where we don't walk around the child discussing whether it has NF1 or not. The pediatrician involved in treating the child will typically quite early on know whether it's actually an NF1. Then a general tendency, low-grade gliomas, over the years, less irradiation, more chemo, and gradually more targeted drugs. And some new drugs are coming, but there's still large unmet medical needs for gliomas in children and adolescents. So disease by disease, diffuse midline gliomas, you already showed several cases focusing mainly on the surgical approaches. So traditionally, that was our old disaster, the diffuse intrinsic pontine glioma, or DIPG. Now it got a new name, and some relatives were identified that behave as badly. And it's a big frustration for all of us, I'd say, because after 50 years of efforts, it's really as badly as it always was. It's remarkable when you come across patients that survive for more than a year or a year and a half. There's a big European registry where they identified something like 2% of confirmed cases were still alive 5 years out, but 2% out of such a large group of patients is very frustrating. For biopsying the pons in Denmark, the policy is only if there's a relevant trial or if there's doubt about the diagnosis. And my experience is with an experienced radiologist, 90 and 95% are actually very obvious. As for the pontine tumors, you have the rare one that doesn't resemble it, and you can come across unusual things. Normally, a good radiologist will be able to say whether it's a clearly delineated pontine tumor, so meaning it's a true low grade, or whether it's a histone mutant. For the pontine gliomas, the only thing we really have to offer, not for curing, but for improving the children, is the irradiation. And it's getting increasingly common to re-irradiate them, just in line with the case presented from Italy, where re-irradiation with a lower dose and in a shorter course will often benefit the children. It will not save them, but it will give them another good time with their family before their final lethal outcome of that disease. As for medications, there have been numerous trials. As I regard it, there are these days no defined standards. Denmark and Sweden have been participating in the Biomedi trial, which is one sponsored from Gustave Roussy. I know my colleagues from Italy have also been part of that. And other Nordic countries are working on taking part in the upcoming updated version of it, where we will soon be testing everolimus versus a promising drug called ONC201. We don't think this will be the solution, but it might show us some signal and a way forward. And meanwhile, that trial assures that we learn something from these children with a terrible disease. There are cell-based therapies on their way. So far as I'm aware, nothing active in Europe, but among other centers, Stanford and Washington State in the US, so the US West Coast, there are several trials ongoing, promising preclinical data. We haven't heard about the breakthrough yet, so we hope it's the future. It looks promising. So if patients were to travel abroad for something promising, I would say that was my suggestion. It should not be for some magical drug. We haven't seen that despite many years of effort. As far as the hemispheric gliomas, maximal safe resection, just like you do in adults. focal irradiation with temozolomide, and the only difference with children as opposed to adults would be that sometimes sometimes we use temozolomide, and sometimes some colleagues prefer temozolomide with lomustine based on US data where they showed somewhat longer disease control, but also with much more toxicity. And we haven't seen whether it actually changed survival or just was more intensive, and therefore it made the patient's disease be controlled a bit more. The other thing is adults tend to get 6 cycles, so 6 months of this temozolomide. We often give them 12 in pediatrics, but that's about the only difference. There was a trial some years ago where we tested whether Avastin or bevacizumab could make a difference, and it didn't. So we learned something about the disease through the associated biology research, but we didn't improve treatment. The only thing where we do different is the few ones with a relevant molecular target. And that would be the ones where you find the BRAF mutation, where there are promising data that in the relapse setting, dabrafenib and trametinib can probably not cure, but they can do good for a while. And I have personally treated children who got another remission, disease control, but not a lasting one. For the most, it will be disease prolonging rather than curing. But I mean, I'm a semi-old man, and prolonging life would be meaningful to me, and I think it is to many patients and their families as well, if the treatment is reasonably tolerated. And then we have the dream target, meaning if I were to have a high-grade glioma one day, I would wish I could get it with an NTRK fusion, because for that we have good targeted drugs. Again, it's not usually the long-term survival, but it can definitely prolong survival for much longer. Colleagues from Sweden just referred me a child that I enrolled on a trial with this last compound. That is a young girl who has a glioblastoma with an NTRK fusion, still receiving another therapy 3.5 years after the diagnosis, still going to school. And that's unusual for a glioblastoma. Without such a target, she would most likely be dead and gone for a long time. Low grades, you discussed a lot. Some are handled by monitoring. That's the rare ones we see at the meetings with the radiologist. Many are handled by you and you only, and a significant number can't be safely resected. They recur or they metastasize. For me, optic pathway gliomas, NF1 or not NF1, are handled completely different. And to that end, it's different from the Moscow approach. And I mean, there are things where we do things differently, and I acknowledge that. I speak as someone from the Nordic countries and being involved for several decades in the SIBE Europe working group on brain tumors. So the perception there, when I entered the field some 20 years ago, it was a low-grade glioma 2004 protocol. At that time, it was for the younger children. We thought if they needed something more than surgery, they should get chemo. And we had the trial where we used vincristine and carboplatinum, and we randomized adding another drug. Would it be doing anything good? And would it be lasting good? And we, for the older ones, one thought that was safe and it always solved the problem. So give them irradiation. And 20 years down the road, 2 things have been learned. Etoposide didn't make a difference. It gave about the same amount of responses, but there were more side effects. So today the standard in Europe is vincristine carboplatinum in many countries. Others use vinblastine weekly, but it would be one of those. And for the irradiation, I'd say that changed completely in the countries where I work and in most Western European countries. Much less irradiation, less extensive surgeries, and today my approach for an optic pathway glioma, unless it was clearly exophytic, so you saw that part that was growing like a fungus on the top, so you could take it away, then I'd say we need some tissue to be sure what it is, and usually these have one molecular driver and one only. So we would like to know which one that is. But apart from that, generally only a biopsy. Unless there's a blind eye and the tumor is sitting up right behind the eye, then of course you take it away and the problem is solved. But if the tumor is in the chiasm, I saw extensive resections, but in the patients that came to me, the tumor had regrown and they needed the other treatments anyway. And often the resections were not that. There was sequelae with endocrine deficits or other things. So it was not the solution. They would need the medication anyway. We use more chemotherapies these years, and we have new drugs coming up. So one thing that came up for the BRAF V600 mutant low grades, first came a study published last year about trametinib, either alone or with dabrafenib. And then earlier this year came a New England Journal of Medicine publication about dabrafenib with trametinib, where we also participated and several Nordic colleagues participated. The kind people in Norway that Radik works with referred patients to me. And this is what it showed. It was a randomization, these two targeted agents randomized against the standard chemo, which is the vincristine carbo. And this is what oncologists call a waterfall plot. So it means 0 means at best during the treatment, the tumor remains exactly the same. If the best response is above, it means the tumor grew, it never shrank. And if the best is 100%, the tumor got away, disappeared completely. And you see that the new agents did much better than the chemo did. So more children had responses. And when you see what we call the progression-free survival on the trial, that means the children go into the treatment and they get either the new drugs, that's the yellow one, or they get the chemo, the black one. And then we just count how many of them haven't progressed after they got onto the drug. After half a year, maybe it's not that important, but going out a year, 2 out of 3 on the new drugs haven't progressed. But only about a quarter of the ones getting chemo haven't progressed. So that's significantly better for the new drugs. It didn't go in the manuscript, but in addition, actually, the quality of life outcomes that were tested here got better and better on the new drugs and got worse and worse on the chemo. So the children on chemo get more and more exhausted by getting these treatments. It's not the child, it's the body that gets worn out. And the ones who are on the new drugs, they tend to get just better and better, going to school and looking like all the others. And based on this, about a year ago, the FDA granted approval to these drugs. Just earlier this week, the AMA came out that they have now approved the trametinib in the pediatric version for this indication. It's still to go out through Europe to be passing, for example, the authority in Denmark that needs to approve that the price is fair and so forth. But I think it will be coming. This is only for the mutant ones. That's the minority. For the fusions, we are still not having approved drugs. For the NF1 low-grade gliomas, silometinib have been used a lot in the US. It's a cousin of the trametinib I just mentioned. It's a MEK inhibitor. And then I actually came to the end of it. We have new compounds coming up later this week at the Society of Neuro-Oncology. I have the pleasure of presenting the optic pathway glioma results for a drug called tovorafenib, which is another RAF inhibitor, but works both on the point mutation, but also on the majority who have this BRAF V600 fusion. And we see response in more than half of the patients. The abstract is published now, and I'll present them Friday morning in Vancouver. That will be Friday evening, European time. So new things are coming, but we still need better treatments. And to sum up, remember to discuss the ones where you don't need to resect within the next hour in your multidisciplinary team. I think that's the best thing. Together we can do it even better. Thank you.
Thank you, Carsten. Very important speech, and of course I can ask a lot of questions and to discuss with you, but I think that we may proceed for the last speech and then perhaps to discuss some items if we have enough time. Matthias, what do you?
Our next speaker will be Mehdi Touat. Mehdi is a French researcher working out of Paris, and is a neuro-oncologist and has participated in a lot of the trials. And actually the reason why we picked him is his participation in the INDIGO trial. So at least in my understanding, now looking more from the adult perspective, now we have something like targeted therapy for something that we call a low-grade glioma and not the pediatric neurosurgeon. So Mehdi, please tell us about targeted therapy for gliomas in adults.
Okay, thank you, Matthias. It's a pleasure to be with you today from Vancouver. I hope you can hear me well and see my screen.
Works very well.
Is it? Okay.
Yes, perfect.
So thank you for the kind introduction. As Matthias said, I'm a neuro-oncologist working in Pitié-Salpêtrière Hospital in Paris. And I have a specific interest on early development of targeted therapies and other agents, and that will be the topic of the presentation today. These are my disclosure. So the presentation was about targeted therapy, and some of the data I'm going to discuss will have some overlap with the prior presentation, but it will be more from the adult perspective. And I will take the example of BRAF mutation for the data we are accumulating on some of the targets that are in the MAP kinase pathway, and then I will take more time to discuss the targeting of IDH mutations and the INDIGO trial. So for the first part, this is the current simplified view of adult glioma classification. Here it's only diffuse glioma, and you can see that it's relatively simple. On the right, you have the group of glioblastoma, which are now defined by the lack of IDH mutation. These are grade 4 tumors with very poor prognosis. And on the left, you can see two groups that are defined in the WHO classification by the presence of this IDH mutation. And this is further subdivided in oligodendroglioma and astrocytoma based on the presence or absence of 1p19q co-deletion. So these have better prognosis, or even sometimes very, very good prognosis in the case of oligodendroglioma. So as regard MAP kinase pathway targeting, most of the data comes from the group of gliomas that lack IDH mutations, either glioblastoma or other more rare glioma type. So this is the view of the core genomics drivers that has been defined from the studies of TCGA and other investigators around the world. And you can see that most glioblastoma have alterations among three core pathways: the TP53 pathway, the RB1 cell cycle control pathway, and this MAP kinase pathway, which is related to receptor tyrosine kinase and a number of intracellular downstream proteins, which can both activate or downregulate the pathway. And a number of tumors have alterations here. You see, for instance, here the EGFR amplification, which is found in more than 50% of glioblastoma. And more interestingly, for targeted therapies, there are a number of very rare alterations, either of receptor tyrosine kinase or downstream molecules that are amenable to specific targeted therapies, and they are listed here on the right. You have ROS, ALK inhibitors, NTRK, FGFR, MET, and BRAF/MEK. So these are all quite rare in glioblastoma, much more rare than EGFR amplification, but collectively, they are seen in about 5 to 10% of patients, and they are therefore important to screen and find because of their therapeutic potential. So I'm not going to discuss the data from all these things, and I just took the BRAF mutations as an example because I think it was the first demonstration that this really works after many years of disappointing results with other targets such as EGFR. So BRAF is a serine threonine kinase that activates the MAP kinase pathway, and when BRAF is mutated, which is common in cancer, the pathway is self-activated constitutively, even in the absence of growth signals. And so this contributes to tumor growth, and the understanding of this biology has led to the design of various agents as discussed before. And these agents target either the mutant BRAF protein or the downstream MEK kinase, and the combination of both inhibitors leads to tumor shrinkage and short to relatively long tumor control in a subset of this glioma population. This is an example from one of the very first VA basket trial in which we participated, and this is a complete response after 3 cycles of single agent BRAF. In adults, the most recent data comes from this ROR basket trial, which combines dabrafenib plus trametinib. The combination has 2 main advantages. First, it works better. You get longer control with combining 2 molecules rather than just using one. Second is that the combination is better tolerated, especially with regard to cutaneous toxicity. So you see here the main results, the response rate in both high-grade and low-grade patients, the PFS and OS, and there is some activity, I would say quite significant activity reported in both, especially in low-grade tumors with very long tumor control in this population in some patients. This is another example from our hospital cohort. You see that as discussed before, most tumors show some degree of shrinkage up to 100%, which is a complete response. These responses are relatively fast, and this is consistent with what we observe in other cases of oncogenic addiction in cancer, for instance, with ALK fusions in lung cancer or NTRK fusions across histologies. Some tumors are super addicted to this pathway, and this is a quite unique example of a young patient with BRAF mutant anaplastic ganglioglioma who progressed after surgery, radiation, and temozolomide. And this was in 2014. And over the past almost 10 years, this patient has received 6 different lines of anti-BRAF, anti-MEK treatments with subsequent responses at each time, and is still under treatment, but progressing after these 6 lines, slowly progressing. And so this really highlights that these treatments can work, can have a very significant activity in these patients. But it also highlights one of the main issues we have, which is the lack of understanding of resistance mechanism and strategies to fight them. And so for this, we'll probably need to work more and analyze and sample tissues prior and after treatment to better understand how resistance develop in this patient, because this situation is quite difficult to manage. So this is just a summary of this part. I just showed you data on BRAF, but the NTRK data looks relatively the same for FGFR. There is also now evidence that it's a real target, and the treatments can work for this patient. And so it provides a proof of principle of the the value of this so-called precision medicine approaches in gliomas after the very disappointing results we had with other targets such as EGFR. There remain some challenges for clinicians. The targets are rare, they are multiple, they are difficult and sometimes costly. And so this can be difficult to manage for pathologists. The treatment stratification has not been well defined. Only, I think, randomized study is the one presented with BRAF inhibitors versus chemotherapy, but we don't know very much how to stratify, how to use optimally these agents. The treatments are not always accessible, they are costly, they can cause toxicities. And then for biologists, we need to find solutions for the other targets that are more difficult and also solutions to understand and tackle resistance. And so to discuss these challenges, to try to find collectively solutions, we created in France a national tumor board for the use of these innovative therapies. It's a web-based board with adult pediatric neuro-oncologists, surgeons, radiation oncologists, pathologists, biologists, and phase 1 specialists. We discuss the different strategies, the different targets, the availability of trials. And as you can see, we already have discussed approximately 100 patients since the creation last year, and approximately 1/3 of these patients were proposed specific targeted therapies programs. So I'll now speak about the other group of tumors, the tumors that are characterized by the presence of this IDH mutation. This is mainly found in low-grade gliomas. You can see that these mutations are found in more than 80% of these grade 2 and grade 3 diffuse gliomas. As said before, there are two different subtypes, oligodendroglioma, which have both the IDH mutation and 1p19q codeletion and are a very good prognosis, and astrocytoma, which have an intermediate prognosis, and these are defined by the presence of IDH mutation, but the lack of 1p19q codeletion. The diagnosis needs this kind of molecular information, which can be obtained by a combination of IHC, for instance, for IDH mutation, the one that is the most common, or also sequencing. So the discovery of this IDH mutation was in 2008, and quite rapidly, researchers have found the mechanism of these mutations and how they contribute to the formation of gliomas and other cancers where they are also found. So these enzymes belong to the TCA cycle. They can be both in the cytoplasm or in the mitochondria for the case of IDH2. And when they are mutant, they gain a neomorphic enzymatic activity, and the mutant enzyme will transform alpha-ketoglutarate into a new abnormal metabolite, which is called 2-hydroxyglutarate. 2-hydroxyglutarate accumulates to extremely high levels, as you can see here on these log scale mass spectrometry graphs, and is also detectable by advanced MRS techniques. And this very high accumulation is going to act as a competitive inhibitor of alpha-ketoglutarate and perturbate several cellular processes such as epigenetic regulation, cell metabolism, and this will contribute to the formation of these cancers. So this discovery has led to the design of several molecules. You can see that there are now approximately 8 inhibitors that have been defined to selectively inhibit the IDH mutant proteins and block the production of 2-HT. So these are some of the very early results. We had a few early phase trials with different kinds of molecules, and I'm going to summarize you the main data. It's quite consistent over the different trials. So first, I think message that came very early is that these molecules are very well tolerated, especially when compared to other treatments we have available for these patients. We don't see much. Most patients actually do not feel anything. And when you look at the rate of grade 3 adverse events, these are very rare. They are found in less than 10% of patients, and they are mainly mild, biological, and transient. So this is really one of the key advantage with this strategy, is that the tolerance is really excellent. Then a second message is about the activity of this agent. So for the activity, we did not see major tumor shrinkage as opposed to what we see with BRAF mutations or NTRK fusions. What we see is more like a long-lasting tumor stabilization, especially in the population of gliomas, which remained with a low-grade type of behavior. And I mean by that, a slowly growing infiltrative tumor without significant amount of tumor enhancement, as enhancement was used in these trials as a surrogate of anaplastic transformation. And so when you look at this waterfall plot, you can see that in high-grade tumors with enhancing disease, there was very few or no clinical benefit, and the benefit was mainly observed as the form of long-lasting disease stabilization in approximately half of the non-enhancing patients. Another important message, which came later thanks to the collaboration with surgeons, is that these molecules are able to cross the brain-blood barrier to inhibit the mutant protein and block 2HG production. And this was very elegantly showed in this phase 0 trial, which enrolled patients with a recurrent low-grade glioma, who were candidates for surgery at recurrence. Patients were treated for approximately 1 month, and then surgery was performed while the patient was taking the IDH inhibitor. And you can see that with different drugs, here ivosidenib, vorasidenib at different levels of dose, we were able to demonstrate significant suppression of 2HG production. So an on-target effect of the drug and some biological changes were associated with this. Among the different inhibitors, vorasidenib was the one with the most favorable property as regard brain penetration, and so this one was selected for further trials. This is an overview of different early phase trial, and you see the response rate and the PFS on top in patients without tumor enhancement, so the low-grade type population. And this is where response are uncommon, they can happen. But the interesting thing is this progression-free survival. And this was in a population for most was already treated with radiation and chemotherapy and recurred after those treatments. In patients with tumor enhancement, there was no or minimal activity, and this was the reason why this population was selected for further development. These are two examples of very rapid progression in high-grade refractory patients, and you can see that in both these patients, there was no response and very fast progression with ivosidenib. So I'm going to show you the main results of the Indigo trial. This trial enrolled patients, pediatric and adult patients, but it was mainly adults with a grade 2 IDH mutant glioma, never treated with chemo or radiotherapy, only surgery before, had a measurable disease, and it was a randomized double-blind phase 3 trials, and patients were randomized between vorasidenib 40 milligram and placebo, and at progression confirmed by a centrally blinded committee, crossover from the placebo to vorasidenib arm was permitted. The primary point was the PFS as defined by the blinded independent review committee, and the trial stopped after an interim analysis showing superiority of vorasidenib compared to placebo, and at that time, a global crossover was performed. So the study was performed across 77 centers. The median follow-up was 14 months. And you can see here the reason for discontinuation of treatment and the number of crossovers. These are the main characteristics of the patient. You can see that the median age was 40 years. The patients were in a good clinical shape. They were approximately 2 years from their last surgery. There were half astrocytoma, half oligos. And importantly, you can see that 80% of the patients had at least 2 centimeters of tumor disease at baseline. This is the results regarding the primary endpoint, the PFS. You can see that there was a strong and significant difference between both arms. Vorasidenib PFS was 27.7 months against 11.1 for placebo. The hazard ratio was 0.39, and this was highly significant. As regard the time to next intervention, which was another key endpoint, there was also a significant difference. This is mainly due to the crossover of placebo patients. But interestingly, you can also see that at 24 months, more than 80% of the vorasidenib arm patients had not received any further treatment, surgery, radiation, or chemo. And so this suggests that you can really control a subset of this population for quite a long time before they receive something different, maybe more toxic. There was no difference in terms of subgroups regarding the primary endpoint. The benefit was seen in all patients. And I will finish with just one example. This is a grade 2 astrocytoma patient. Woman had surgery in 2020 after a seizure. And she was proposed what we call a watch and wait strategy. So she was followed for approximately 1.5 years. And during that time, as expected, the tumor residue in the left temporoinsular region slowly grew. So in the middle here, this is the baseline vorasidenib imaging when she entered the trial. At that time, she was blinded, so we did not know what she was taking. And progressively, over a course of 18 months, the patient has been showing a progressive response of the tumor residue, and she's still in the trial doing very well clinically, has no complaint at all, no toxicity, and still experiencing response approximately 2 years after enrollment. In terms of safety, as I told you, it's extremely well tolerated. The only significant adverse events we see are increase in liver transaminase, and you can see that it's grade 3 or more in 10% of the patients in the vorasidenib arm, and this sometimes justify interruption of the treatment or dose reduction, but it's very rare that we have to discontinue vorasidenib due to these very mild biological adverse events. You can see that in the trial, it was only 3.6% of patients discontinuing due to adverse events. And so to conclude on this part, these IDH inhibitors have showed in early phase trials their excellent tolerance, quality of life as compared to other available treatments, their capability to penetrate the BBB and hit their target, and their efficacy mainly in non-enhancing, slowing, growing low-grade tumors. The Indigo phase 3 randomized trials demonstrated the superiority of vorasidenib compared to placebo in terms of progression-free survival. And the ongoing development now regards combinations in recurrent high-grade tumors, maintenance strategies, and different type of trials, which will be launched in the coming years to address now the key questions we have regarding the optimal patient population, the sequence, the duration of treatments, etc., etc. I just finished with this view, which is a summary of the different targets we have in circumscribed gliomas, in diffuse gliomas. And so here I discussed a little bit today about the BRAF mutations, which are found in both pediatric and adults, and the IDH mutations, which are found mainly in adults, as you know. So thank you for your attention.
Well, thank you, Mehdi, for this wonderful and quite intriguing talk. Again, talking a bit from the adult perspective, where we did not have so many things going on in the chemo department, let me call it like that. I think we are quite rapidly running out of time. So maybe just a few of the questions in the chat, and I apologize if I cannot answer all of them. One was, I guess, to Carsten. What is the best time point to whole exome or whole genome sequencing? I guess Mehdi can answer to that as well. In the recurrent setting, when the glioblastoma or the diffuse midline glioma grows back, or already in the primary situation?
Thank you. If not possible, if you're short of resources, I would say the panel sequencing, so checking for the BRAF and for the NTRK and such things at diagnosis would be good, because it's not that they are coming along the way, either they're there, and it's good to know, because in the high grades that tumor will recur at some point, and then you can immediately put in your targeted agent. For the low grades, if you know the driver of the tumor, sequencing is not as important outside of the research setting. For the pontine gliomas, we all dream of sequencing them and finding the target. I know there's one patient with a thalamic diffuse midline glioma in my hospital, a young man who was 20 or 22 at diagnosis, and he benefited from it. But otherwise, we have sequenced a lot of a lot of the DMGs without finding any obvious targets. So every time we do it, because it's a desperate situation, but the findings are really rare. So I would do it on the tumor that you cannot surely classify. That would be where I did it. And for the infant with the hemispheric glioma, do it because you could find the BRAF, the NTRK, the ALK, whatever. But really the rare ones, the typical pontine one, yes, if the family is desperate and you can help them calm down with that, yes, but you will most likely not find treatment. Similarly for the glioblastoma, if you excluded BRAF or NTRK, you will probably not find it. I don't know if Mehdi has anything to add to this pediatric approach.
I think from an adult perspective, I mostly agree with you. What I would say is that practically, I think, we do a lot, like so many procedures to our patients that are quite expensive. We do a bunch of MRIs, controls, whatever. And so to me, spending maybe $1,000 or maximal $2,000 just one time to get a better understanding of the tumor and maybe have the luck to find something rare is really worth it for our patients. We know that unfortunately, many of them die quite fast. And so I think we just like from this practical perspective, I would advise doing it without thinking too much and choosing the wide assay, something either a large targeted panel or whole exome sequencing. What is important is to also screen for the fusions, because these need specific dedicated assays. And so pathologists really need to look for both point mutations and fusions, because both type of targets are found in pediatric and adult gliomas.
Just to add one thing, that in the rare patient where you found these molecular drivers and now the tumor recurs, I would always sequence them to see, is it NTRK? Is there now a resistant mutation? Is there something else driving it? So for the few where you have the target, if they don't respond there more, I would also invest in sequencing them upon recurrence, because that's where you can sometimes find, for example, that patients who are on larotrectinib with a MEK inhibitor can be stabilized again, their situation. So they would be the ones benefiting the most.
And another thing because I think there are many surgeons listening. So sometimes these assays are quite difficult and complex. And so we need, as you know, good amount of material, and frozen tissue is really a help. If it's possible to organize locally, it can be really of great value for these patients. So if you have locally the possibility to freeze tissue, I think it's really something to consider. Even though at the moment you do it, it does not seem helpful. It might become helpful in 2 years.
Okay, thank you both. Sergey, some comments from your side.
Unfortunately, we even cannot answer all the questions, but there is one of the general questions, and I think it may be the last one. So what are the other approaches from our colleagues in Europe and from USA, distinct from the one utilized in Burdenko, Moscow, and the one that Sir Carsten Newsom has just explained? So I can briefly define my position. It is not so aggressive that somebody may think. So I consider surgery for chiasmal gliomas in patients with hydrocephalus for the reduction of the tumor size in GN tumors, and for the biopsy to know the histology. These are the indications for surgery. So no surgery in neurofibromatosis type 1 and no surgery in small tumors. So our strategy still, the first line therapy is chemotherapy or target therapy or in cases of failure, radiosurgery. So radiosurgery in cases of older children, in small tumors, and in cases of recurrences. So, and doubtful indications for radiosurgery are in young children and in neurofibromatosis type 1. But we should keep in mind that we speak about the modern conformal radiosurgery, proton therapy, gamma knife, lean accelerator, with minimal influence to the surrounding tissues. So this is our position. So perhaps somebody may comment it from the, as our participants ask, from the USA or Europe. So all of the speakers are from the Europe. Perhaps you may comment this position.
All right. Sergey, since we're really over time, so I think it might be best to just conclude that, but simply because we're over time, that shows that this webinar has caused a lot of interest. We've seen a lot of we've heard and listened to a lot of very good talks, a lot of exciting things are going on. I learned a lot of things from the pediatric side. Thank you very much for your talks. So I guess we'll call it a day. Sergey, what do you think?
So I think that this webinar was very useful, very nice. So we have up to 300 participants. This is the maximum number for all our activities. So we had a lot of questions, even we could not answer all of them and discuss all the items. So I think that we have to proceed with our webinars in the future as they has become very popular. So from my side, I am very grateful to all the participants, to the EANS office, to ANAREC, to our speakers, to moderators, and personally to Radek for the organization of this very nice webinar. Thank you.
All right.
Thank you. Have a good night.
Thank you. Bye-bye, everybody.
Yeah. Bye-bye. Bye-bye. Thank you.